hello, everybody. While waiting for everybody to come in and to start the afternoon session, there are still some Slido questions which I think we have time. We will just run through. Okay, maybe I'll ask this. What advice would you give an athlete to undergo basic cardiac assessment before active sports?
All right. So, I mean, in general, it depends what type of sports they are going. In America, they classify it as a very intensive sport, not so intensive, golf, so on and so forth. So, those who are going for like marathon, high intensity workout, I think the basic that we need to do is to see a physician, do a proper assessment, make sure there's no underlying risk factor, and then the basic ECG will be important. If you ECG, it's very important to pick up subtle things like left ventricular hypertrophy. Now, in America, I think the top two cause of death in athletes, we don't have a data in Malaysia. But I think in America, those athletes usually die of either hypertrophic cardiomyopathy or those born with the anomalous coronaries. Like our cyclists, remember our cyclist Hazizo have anomalous arteries. So if you have suspicious, do an echocardiogram, make sure there's no left ventricular hypertrophy or hypertrophic cardiomyopathy, or sometimes you can subject them for stress tests. Stress tests sometimes can pick up a sign like we illustrated earlier. All these ST depression, all these should be subjected to further investigation.
What about you? What about just doing a basic ECG? Would that be suffice?
It depends on the age group actually. If you are in the younger group, patients have actually has, as you say, hypertrophic cardiomyopathy, you pick it up. Maybe arrhythmogenic right ventricular dysplasias, the other one that they die off suddenly. In the older group, it's actually coronary artery disease. These athletes actually die suddenly because unknown coronary artery disease. So if you're actually going, and I have a few patients who actually go for high intensity, like mega marathon, I would subject them to a stress test as well as an echo in that particular elderly group, older group.
For the CPG on dyslipidemia, it is recommended to repeat transaminases not only at baseline but also at 1 to 3 months of starting therapy and following change in dose. I would like to know the opinion of our panel. I sat on the CPG panel and I can say that actually they find that there is sometimes an increase in on the enzymes after you either initiate or change or increase the dose. So that's why they recommended it. Is it better to avoid statin in a patient who is got a mild dyslipidemia and pre-diabetic, since statins is known to be diabetogenic, but use ezetimibe to treat his dyslipidemia?
I think if it's mild dyslipidemia, there are a whole host of lowering risk by lifestyle first. Ezetimibe is actually good. The evidence is okay, not as strong as the statins for reducing cardiovascular disease or MACE. So I think in pre-diabetic and mild dyslipidemia, Crestor and atorvastatin, there has been a view on that Crestor may be the statin that would cause raised diabetes, but atorvastatin didn't come out as that's the case.
All right, but basically yes, all statins, especially at high doses, just increases your CV risk, but still the benefits are there. And ezetimibe probably doesn't want to reduce your LDL to the level desired, because ezetimibe by itself only reduces LDL by about 15%, 18%, unless you take it together with a statin. I'll take one more question, and I think this is something that maybe I ask Shamruz. Nowadays, some of the labs do TROP-I. So a lot of people are doing TROP-Is when they do order a GSP. So what is the use of this? Can you comment on the use of this qualitative TROP-I in general practice? Any use in late presentation of chest pain?
Well, personally, I wouldn't recommend TROP-I for everybody. It's the same like cancer marker. sometimes it's mildly positive, then it will lead to unnecessary extra procedures, extra tests. I think you always use the test in clinical context. So just because it's available, you don't have to do it. Certainly in patients with recent onset of chest pain or patient with stable CAD but new worsening angina, yes, you should do high sensitivity troponin actually to diagnose or exclude acute coronary syndrome. But not routinely in everybody. I don't think so. I don't know about you. Yeah.
Yeah, I think I agree. You know, yeah, you do all that if patients come with raised drop eye, but patient is completely asymptomatic, and then you open a can of worms. There are many, many causes for raise of drop eye, just not only cardiac. So I shall pass it over to Dr. Koh to handle the second session.
This round, we're going to make it more chill and relaxed. I'm not too sure about relax because I'll be on the floor interviewing some of you all. Just interviewing, relax. So this will be something like an ECG or X-ray short cases. Okay, so we'll be presented by our distinguished panelists here, and my co-moderators will be Dr. Choi. And let's start off with the first case of ECG. Who's number one? Nazrul, come.
All right, so I had a 60-year-old gentleman. He came in with a history of epigastric pain that started in the morning. So he came to see us sometime late in the morning, around 10 a.m. The pain started somewhere around 7 a.m. in the morning. So his blood pressure was 110/60. He had a pulse rate of 60 to 70. His physical examination was unremarkable. So we did an ECG, and this is what we saw.
So anyone would want to volunteer first to interpret the ECG? Yes, sir. Come, pass the mic. Hi, sir.
Let me say, I think he's got an inferior infarct.
Whoa, excellent. Give a round of applause. Spot on. All right. So why do you think there's an inferior infarct? Again?
Describe the
Elevated
ECG,
ST segments in 2, 3 and AVF.
Yes. Nazrul, is it correct?
Yes, that's absolutely spot on. Yeah. So this patient, based on that ECG finding, he has got an inferior myocardial infarction. Yeah. So let's just go back again to the ECG. So if you look at lead 2, 3, and AVF, you can see that the ST segments are elevated. Yeah. Sometimes in this kind of cases, you can also see reciprocal changes. So if you look at lead 1 and AVL, you do see some ST segment depression as well. Yeah, so spot on, this gentleman actually had an inferior MI, and we brought him to the cath lab, and he had a PCI done to his right coronary artery. Yeah.
Just for the sake of the audience, right? So if you see an inferior MI in your clinic, will you foresee any kind of a complication that you could have picked up from the ECG as well?
He may have bradycardia.
Very good.
Yeah.
And sometimes bradycardia due to complete heart block as
Yes,
well, I
complete
think,
heart
isn't
block,
it? So
yes.
maybe at your clinical setting, you can look out for complete heart block in part together with the inferior MI.
What kind of anti-angina or pain relief can you give for this patient with inferior infarct, especially if the BP is low?
Imagine in the GP setting now, the patient is sitting with this ECG, what they can do first?
Well, it depends on what medications that we have. If we have any IV, I think morphine is usually the first line of treatment when patients come in, but of course with the low blood pressure, you're a bit concerned that you can... So I'm seeing some people shaking their heads, so we don't have morphines in the GP center. So if you have the strongest pain medicine that you have, I would assume be tramadol. If you have tramadol, then give him a stat dose of IV tramadol and send him over. Well, we probably wouldn't. So the thing about patients coming in with inferior MI, when they have low blood pressure, of course, the first thing you want to do is load them with antiplatelets and then send them off as soon as you can to the hospital. In terms of pain medication, I would assume whatever IV medications that you have, if you've got tramadol, give them tramadol. If you've got whatever oral medicines, PCM, what if you can give them, give it to them and then send them over straight to the hospital. The other thing that I would like to say, if patients with an inferior MI and they come in with hypotension, what you can do in the meantime, if you do have an IV drip and such, you can actually load them with fluids to try and help push up the blood pressure, because most often than not, they have right ventricular failure, which actually responds to boluses of fluid. So you can do that in the meantime while waiting for the ambulance to come by. Okay, so the second case is a 70-year-old man. He came in with symptoms of dizziness and chest discomfort. So his blood pressure was 160 and he had a pulse rate of 90 beats per minute. Again, physical examination was unremarkable and this was his ECG findings.
Take about 1 minute to have a look at this ECG and digest. Okay, is it a posterior MI? Is it a right bundle branch block? Is it a left bundle branch block or just a normal sinus rhythm? Okay, back to your ECG.
From the ECG, I can see that there's a ST depression from V2, lead V2 to V4. Yeah, and V5 also actually. So it can be reciprocal changes. So in V3 to V4 is actually, V2 to V4 is anterior leads. So reciprocal changes might be at the posterior. So I would suspect posterior MI in this case. And for confirmation, I will do a posterior ECG. Thank you.
All right. So, Nazrul, what do you mean by reciprocal changes?
Okay,
So for these two ECG, I think the first ECG illustrates the reciprocal changes, but there's the ST elevation.
Correct.
Now, what do you mean by this?
Okay, so what the Dr. meant actually that, the V2, V3 is actually looking at the anterior part of the heart. So this gentleman actually is having an infarct involving the posterior segment, which is at the back of the heart. So the ECG would record an opposite image of an ST elevation, hence why you get a deep ST depression. So in this kind of cases, when you see a very deep ST segment depression in the anterior leads, V2, V3 namely, you would want to extend the ECG leads to the back. So we would put in a V6, 7, 8, and 9 at the back, and then you would be able to see ST elevation, right? So that is what it means by mirror image.
So our audience mentioned, doing posterior leads will be helpful in this case, right?
Yes.
Like how rightfully. Do you think flipping the ECG, as in just looking it the other way around as a mirror image would be the same?
I've actually never tried that, but I guess if you flip it around, you would actually get an ST elevation. So, but I don't think medico-legally that's advisable.
I agree.
So, yeah.
About this ECG,
Okay.
which do you think is the culprit vessel for this patient?
Okay, so I'm a bit biased because I did the cath for him. It actually was the circumflex artery. It was a dominant circumflex artery. So it also covered the posterior segment of the heart and it had a non-dominant RCA. But at times you would expect them to also have a RCA involvement. But for this particular guy, it was the circumflex actually.
So most posterior MI is either the RCA, usually the dominant part, or the dominant circumflex for this patient. All right.
Yeah.
In general, again, PVCs are very common. In fact, it's one of the common incidental finding in ECG. So if we get that, first of all, of course, ask a thorough history whether they have any symptoms or any underlying risk factor for developing the PVC. Because PVC itself is not the underlying problem. The previous few cases we have demonstrated that some PVC can be due to ischemia, some PVC can be due to underlying non-ischemic cardiomyopathy. So if the patient does have a history of shortness of breath, family history of dilated cardiomyopathy, those kind of PVC definitely are not, you're not supposed to just say it's a benign PVC. But most patients that come for screening, if I see the PVC, I'll always reassure them, don't worry, it's normal because your physical finding, your history are nothing. So, but again, just give them a bit of advice. If in the future you have any problem, do remember to come back to have a further investigation. Same like any other disease. A lot of incidental, like for example, funny moles, for example. You don't go and biopsy all moles and scare the patient that it might be melanoma. But of course, tell them if any changes in the color, the size, or whatever symptom, please do come back. That is a very important thing. Because I have many patients that saw me earlier. He said the most typical history is doctors say that these are usually no problem, so no need to come back ever again. This is the one that the patient will wait until the very end. The heart is dilated, PVC from 10 PVC a day to 20,000 PVC a day. This one is these are the patient that actually going to become worse. But in general, it's really, really not a lot of them. minority of them, but we still see a substantial amount of them. Yeah.
Just to add on to Dr. Koh's comment, remember the first ECG was complete heart block. If you do see a complete heart block in your clinical setting and then you see PVCs, that on the other hand can be quite dangerous, because when you have complete heart block, bradycardia, and you have PVCs, those PVCs can actually send the patient into some kind of TOSA. That's why it's not uncommon to see people getting ventricular fibrillation in the acute onset of inferior MI.
Okay.
All right.
Next presenter is Dr. Navi.
Okay. So if you were paying attention to my earlier presentation, this will be a walk in the park. So it's a 54-year-old male, newly diagnosed hypertension, referred for abnormal ECG during medical screening. So, and I've put the options on the side.
So actually, this ECG for me, I would think that this is a LVH pattern, left ventricular hypertrophy, as evidenced by first voltage criteria. Is actually fulfills the Sokolov-Lyon criteria of deep S wave in V2, V3, and plus the R wave in V5, V6. And also there's a ST depression with a T inversion at the lateral leads, V5, V6, 1 AVL, which is the non-voltage criteria of LVH. So, and there's a there's no concordant ST elevation or ST depression, and there's no excessive discordant, so it doesn't fulfill the modified Scarbosa criteria to say that this is a MI. So I think it's a LVH. Thank you.
Fantastic. I don't think so. I need to go to my explanation slide. Your explanation is better than my slide.
Can I just push it a bit further? So very descriptive. But how would you differentiate this from the last option, which is a non-STEMI? So non-STEMI can also have ST depression as well. Why didn't you choose non-STEMI?
For me, I would still think that, okay, if the patient, I will evaluate in terms of history, also physical examination. So if a patient came to me with acute onset of chest pain, so definitely first thing is the only time sensitive one is ST elevation, or we say that it's an occlusion MI or STEMI equivalent. Other than that, once I rule out that, then I will take, if patient has chest pain, typical with ACS, with risk factor, then definitely I will review the troponin. If the troponin is raised, then I will treat as a non-STEMI. But even if the troponin not raised, patient with risk factor and history, typical chest pain, then I will treat as unstable angina. Yeah.
Okay, I think you deserve the luggage bag. We give you the luggage bag, right? So, I mean, very right. I mean, rather than just the ECG, the history is very important. This was just a routine ECG during a medical checkup. So that probably excludes non-STEMI. But if you are suspecting that silent MI, maybe a diabetic patient, like what you mentioned, a troponin may be useful.
All right. Any questions for this ECG? Excellent, excellent. Okay.
Next.
No questions? Dr. Jama? No. Okay. The next one.
Okay.
Navi?
Next one's an 80-year-old male, underlying chronic renal failure, not on dialysis yet, presented with vomiting and breathlessness. So that's the ECG. I hope it's clear.
So sometimes when we are thrown a ECG, you may not know the answer straight away lah. But it's a good practice to always, in your mind, go through a systematic order and try to describe an ECG. First of all, you look at whether it's a sinus rhythm or not. Is there a P wave in front? And then later on, you look at the PI interval. Is it normal? And then describe the QRS complex. Is it like LVH or is it a small complex? And later on, the ST segment, is it elevated or depressed? And then the T wave pattern. So this kind of description, you have to practice it every day lah, in your mind.
PR is prolonged and then tall tented T waves. And then, you look at the history as well. The patient has chronic renal failure, not on dialysis yet, so that's also a giveaway. Vomiting probably is uremic, so that's the whole reason he's been having this vomiting. So, I mean, there are other changes that you can see in patients who present with hyperkalemia. May not really vary with the degree of how high the potassium is, but in very high levels of potassium, then the patient may present with, sinusoidal waves and loss of P waves. Most commonly, you will see the tall tented T waves, and if the potassium is higher, I mean, I don't know, Ko, does it really correspond to the potassium levels, or sometimes, is there a correlation?
Not really, because sometimes you can have a potassium of 6, but you might not, just see maybe a bit of tented T wave.
Yeah.
It depends on how do you say, how well the patient tolerate to the potassium. For example, acute, if you load me now with IV potassium acutely, any
probably have-
potassium of 6, you can see all these changes.
Yeah.
changes. If you have someone with a chronic renal failure or even renal failure and dialysis, you always see, hey, the potassium like 6, but the ECG is
Can be normal. Yeah. All right, so those are the other changes that you may see: white PR, white QRS, peak T wave, and then of course the worst case scenario is when you have sinus waves, sinusoidal waves.
Okay.
Dr. Nabi,
right.
this, maybe some would like to know, how do you tell the difference between an acute MI who presents with vomiting, very hyperacute MI, versus hyperkalemia in your case?
Well, I think possible patient could be just having vomiting when he has an acute MI, but I think the other thing is also doing serial ECGs. Sometimes if you're not sure, you do a serial ECG and you can see like 10 or 15 minutes later, you can see the ST segments starts to go up. Or again, you could probably see reciprocal changes in the inferior lead.
Another thing is the territory of the leads.
Yeah.
So usually in myocardial infarction, they involve one territory. Of course, sometimes we can see two territories, but you
This
see
one
the
is
tall tendon T
widespread.
wave is widespread all over almost all leads.
Anybody want to ask a question?
Where's the P wave? P wave. And Naveen, where's the P wave?
P wave is, wait, let me see. There, P is very prolonged, right here. You can probably see it clearer in some leads here. Let me see again.
Okay. So in the ECG, I understand your question because a lot of people ask the same question. Sometimes it's very difficult to differentiate, alamak, which is P wave, which is T wave, and which is QRS. Now the QRS complex always have a peak one. Either the peak is pointing up or pointing down. And the peak has to be very sharp. It's like your Menara 118, very sharp. You need to have that pointy thing, then you know that is the QRS complex. So once you recognize the QRS complex, it's very easier. On the right side is the P wave. And usually it's a bit smaller. And on the left side, usually it's the T wave, which is the taller one, most of the time. So you just need to recognize the QRS complex. And in most ECG 12 lead nowadays, they are simultaneous ECG. Means that, let's say, lead 2, you're not too sure. All the complex looks about the same. Then you compare to your simultaneous ECG, V5, V6. And you can see that clearly. This is definitely the QRS complex because they have, both peaks are a sharp one. So you draw a line down here. You know that this is the QRS complex. And before that, definitely is a P wave, very clearly. And after that is the T wave. And the PR prolongation, I'm not too sure about this. This is not really prolonged.
Yeah, it's not really prolonged.
But what
So
is
that's
striking
why
is
my clue is here.
Correct. The striking thing is most of the T wave can never be, usually not going to be taller than the QRS complex, especially in V5, V6. You can see that the V5, what do you call it? The T wave is much, much taller than the QRS complexes.
I think people were confused because when the T waves were so tall and
Yeah,
tented,
correct.
then they were thinking that's the QRS complex,
Yes.
but it's actually, this is the P and that's the QRS, and that's the T wave there.
When it is, let's say the potassium is up to 7, sometimes you can't even see the P wave because the
PR
PR
is
is
prolonged.
really prolonged. The P wave will hide inside the T wave. Then you only can see a bump and then a sharp wave. So you're not too sure which is which. So this is still quite clear. Okay, thank you very much, Naveen. So our next presenter is Dr. Shamrus. So let's see what Shamrus has in his bag.
This is the point.
Case 1, 42-year-old gentleman, admitted with 3 weeks history of worsening shortness of breath, cough, but no fever. White cell count was elevated at 14 when he came in, and the NT-proBNP was 1,800. So this was the chest X-ray.
Some of y'all have X-ray in the clinic.
Okay, exactly. So maybe you are familiar.
Okay, show back the X-ray again. I think everybody want to look at the X-ray.
So may I get you, sir, to maybe give a comment on the X-ray?
What I can see is the
CT ratio seems to be high, and there seems to be increased upper zone diversion. The causophrenic angle seems to be clear. I think I can see some curly lines.
Thank you so much. Go back to
Wow,
you.
congratulations. I think you described better than our radiologists.
Yeah,
Cameras.
better than a report. Yeah, I agree. Well done. Yeah, I guess the most obvious with that kind of story, sometimes I guess when people look at the X-ray, they look at the white blood cell count being elevated. They may treat this patient initially as possible bronchitis or pneumonia, which actually was what happened in this patient. So he was treated initially as acute bronchitis, but the symptoms did not improve. So subsequently was referred to me, and then the echo actually showed the ejection fraction for this gentleman was actually just 20%. So the clinical picture was actually acute heart failure. So when I auscultate the lungs on examination, there's widespread crabs everywhere, but he also has some wheezes. And there's no known history of any underlying heart disease or family history. I guess the initial doctor just treated as acute bronchitis, presumably because of the elevated white blood cell count. But pro-BNP can also be elevated in pneumonia. So clinical history and examination are still number one. Okay? Always correlate your findings with the clinical examination and history.
Dr. Shabra, where is the curly lines?
So there's some fluids in the fissure there. So if you, I don't know, if you can convince your eyes. So usually curly lines should be some lines coming off from the periphery towards the heart. There's also like curly A lines coming from the heart towards the periphery of the lung. But the most obvious changes will be cardiomegaly, and then you can see congestion in the hilar region, usually called as a backswing pattern. And then sometimes you can see pleural effusion, blunting of the causophrenic angle, and obviously the upper lobe diversion. The curly A, curly B, eye of faith, maybe you can convince yourself, having known the story and the history.
But the right side fluid in the fissure is quite obvious.
This is quite obvious there.
All right, good.
Okay, good, very good. The next one. So just some of the typical findings for chest X-ray in acute pulmonary edema. So case 2, 55-year-old patient, 1 week history of productive cough, fever, and shortness of breath. And this time the WBC was 11, pro-BNP was 1,000. This was the X-ray. Anybody would like to comment? Options? Go back to the X-ray.
So far for the heart, I think the cardiothoracic ratio is quite okay. Causophrenic angle over the left side is quite okay. The right side is a bit diffuse. Lungs a bit consolidated over the right lower zone.
Anybody else? I think
Thank you very much. I think
there's another, gentleman.
There's an opacity in the right lower base. So I think it's a right lobar pneumonia, basal pneumonia.
Very good. Do you think right middle lobe or right lower lobe for extra bonus points? Lower lobes. Why do you say that? Okay. Sometimes it can be very hard to distinguish between middle and lower lobe. One additional clue you may want to look for is the silhouette sign. So if you don't see the right heart border clearly, then it may be the right middle lobe involvement rather than the right lower lobe. And the other thing that's typically commonly seen in pneumonia is the air bronchogram. You shouldn't really see the bronchioles on the X-ray unless there's a process in the alveoli, the air space, which makes the bronchiole more obvious on the chest X-ray. Okay, and again, in this patient, the pro-BNP was elevated. Do you think that's normal? So everybody knows pro-BNP we do for heart failure, but in this patient, the anti-pro-BNP was 1,000. Is that unusual? Maybe Ko or Choi, you want to comment, or any of the cardiologists?
Well, I think for a 55-year-old without any renal failure, having a pro-BNP of 1,000 plus is a little bit elevated. So maybe an echo to look for diastolic dysfunction. It's a cause.
So antibronchial is a little bit like troponin. It's not just elevated in heart failure. There are other processes that can also push your NT-proBNP up. In sepsis, especially in pneumonia, if you have gram-negative sepsis, the NT-proBNP can also be elevated. So again, history, clinical examination to correlate with the findings, and then you can make your final diagnosis. Okay, any other comments or questions?
2 quick questions. Somebody asked, I would like to ask expert opinion on having a rapid TROP blood test available at GP. Is it good to have it, and is it justifiable to make decisions if used on our patients? That is, you have a TROP-T. Navin, you want to advise?
I think it's useful because that's what's done even in our emergency department when the patient presents with chest pain and they're suspicious of an acute coronary event. Then a troponin will be able to help. But the thing is, you also need to be sure about the onset of symptoms, and if you're doing it too early, then sometimes it can be negative as well.
I would disagree with you. I would say that maybe not in the GP setting, because it's actually sometimes a can of worms. If it is raised and you think it is symptoms, is it very easy, okay? But if the symptoms, like you said, you do it too early and it turns out to be negative and you tell the patient, hey, everything is all right, he may go back and have an infarct because you just checked it too early. And on the opposite, if the TROP-T may be raised and it may not be due to a coronary disease. So at a GP level, you really need to monitor and follow up these patients, which sometimes you may or may not have that benefit in the GP practice. In hospital, we'll just admit the patient, and if he survives the night, it's probably okay lah.
Medico-legally, yeah, you're probably right. But even in emergency, you do see a lot of patients coming in and they would do a troponin, and sometimes it's too early. And the next day you see the patient in your clinic and then you repeat the troponin, it's elevated.
That's how they asked you. That's why all the patients seen in ER, if it is negative, the ER MO always tells them, you must come and see the cardiologist the next day, or if symptoms get worse, come back immediately. That's how they cover the asses. Otherwise, those days, the patient just to go home and say, lousy hospital. They go to another hospital and they diagnose that the patient had a coronary event.
I mean, you can still utilize in a GP setting, but you need good clinical judgment and what to do next.
Okay. Another last question is about the use of high sensitivity CRP as a routine blood screening. Yep, you want to answer that?
I think for HSCRP, which you're right, like homocysteine also, we see it often used in screening tests. And there have been several patients from my experience who have been advised to see a cardiologist because the HSCRP is raised. I think this one is even more non-specific because in any case of inflammation, it will be elevated. So yeah, we can assess them and we have to go through the whole works basically.
So basically there are good points and bad points about using it. You have to assess the patient as a whole. Just because his HSCRP is slightly raised, it doesn't mean that he has to see the cardiologist right now, otherwise he'll drop dead. No, not really. You still have to go through the CV risk factors, etc., etc. Okay, back to you, Ko.
All right, so the next speaker will be Dr. Su. So, Dr. Su.
Mine is quite straightforward. This one. Okay. This kind of case once really stressed me out. 60-year-old guy with a chest pain and ECG shows. I think this is going to be very simple and everybody should get it right.
The Slido? No, nobody answered in Slido.
Okay, you see, 100%.
100%.
Congratulations. When you see, this is what we call tombstone. These are the anterior leads, and we have massive ST elevation on the anterior leads. And we also have the reciprocal changes in the inferior leads. To a certain degree, some on the lateral here, but we have a really predominant marked ST elevation up there. The rhythm is sinus. There is no heart block. If you see heart block in an anterior myocardial infarction, that means a very extensive myocardial infarction has happened. This patient needs immediate attention. And this guy can very quickly, rapidly deteriorate in front of my eyes. Has few tragic, but life-saving is actually sent to emergency department, ASAP, especially to angioplasty primary center.
Yep. Dr. Su, so usually which artery are the one is the culprit artery that's responsible for these kind of changes?
This would be a left anterior descending. If it was a left main, one would expect to see some changes in the inferior leads as well. If you get ST elevation interior leads plus the ST elevation inferior leads, then you worry about a left main being occluded.
Choi, Dr. Su was saying that in this case, anterior MI, we also look for heart block. But this time a bit different. If you have heart block in this, mean bad news. What do Dr. Su mean?
Yeah, I think what Dr. Su trying to tell us is that the proximity of the lesion determines the prognosis. So LD is a very long vessel. I guess if it's blocked right at the apex, probably nothing will happen. But if the stenosis is, like what he mentioned, very proximal or even left main, maybe that is why it involves the septal branches. And some of the septal branches can actually supply the AV node as well. So when you have this kind of AV block, I would believe it's a very high and very proximal degree of LED stenosis. Maybe that is why.
Yep, correct. So the RCA often supplies the AV node. So that's why if you see an inferior infarct and you get a Wenckebach or even complete block, that is because of the AV node involvement. And AV node usually have dual supply. Another one from the what do you call that, in the left coronary artery. That's why AV node involvement in the RCA infarct, sometimes you leave it alone, it will get better over time because the left side is going to supply back. But in LAD, you might not get it back because when it infarcted, as Dr. Choi said, it's very proximal. It involved the AV node and sometimes involved the bundle branches, and bundle branches are high degree AV block. In the guideline, if you have a anterior MI with a complete block, the indication of pacemaker is very strong. You have to implant a pacemaker because most likely they may not recover. Right.
The next case, that just explains everything here.
Okay.
A 30-year-old young man with chest pains and fever. What does the ECG shows? Acute pericarditis, acute anterior MI, acute pulmonary embolism, or early repolarization pattern. Remember, this is a 30-year-old young man, chest pains and fever.
MI? Yes or no?
Yes.
Still possible. Still possible. We have one say possible.
Okay, so let's review the answer, Dr. Su.
Okay, looking at this, you can rightly exclude an acute anterior myocardial infarction because the STs are a bit different in this case. They are actually concave upwards rather than the previous one, which is a tombstone appearance. There is all uniformity here in 1, 2, AVL as well, and you can see a concave pattern up the way with a bit of a takeoff here. Acute pulmonary embolism usually just give you a right ventricular strain pattern. You get anterior in the septal leads, probably with repolarization defect as well, but you won't get such an extensive concave patterns in acute pulmonary embolism. Chat with pain and fever is a giveaway, so the diagnosis would be pericarditis as diagnosis of choice. The other pattern that you can see is a concave, which is unusual. You would get it in AVR, a concave downwards, and that would be also compatible with pericarditis. I think the history of the chest pain would be very useful. If the chap tells you that it's actually pain when it's actually breathing in or out, that also would be a giveaway. And you might hear a rub on clinical examination.
Mm-hmm. So what is the treatment, Dr. Su? If they see these kind of cases in the clinic, should they refer to the cardiologist? What do you think?
Well, I think this guy would be seen in ER because of fever. First thing of all, you would actually try and find out whether this got associated pneumonia, which you may get pericarditis, which is quite a common thing. Viral illness is very important, especially in this country, to find out what is the cause of the fever, because dengue also you can get pericarditis along with other kinds of viral illness. So the main proponent is actually find out what is the cause of the fever first.
Okay. So, Dr. Shamros, if you see in the ER, would you admit the patient?
Yeah, I would admit the patient because he came with some symptoms. There are some ECG changes. The question is whether this is just a simple acute pericarditis or is it myopericarditis, which can trigger certain arrhythmias, which can be, fulminant and, catastrophic. So I would want to at least monitor and do the cardiac markers, get the baseline echo. If the ejection fraction is good, no regional wall motion, no pericardial effusion, usually most of these myopericarditis cases, they usually resolve on their own. Analgesia, people try NSAIDs and things like that. But there's no hard and fast rule about it. I mean, fulminant cases, sometimes people use steroids, high dose to manage these patients. Nowadays also we have the option of doing cardiac MRI, which can highlight myopericarditis quite accurately. So a few things to consider there.
So it means that probably we have to make sure the TROP-T is not raised like this.
Echo normal, cardiac markers not elevated, then there'll be low risk.
These are not territorial. You see all widespread ST elevation in most of the lead. And classically, sometimes you can see the AVR, the ST segment depression, PR segment elevation. These are quite classical for pericarditis. Right.
First question is to you, Ko. What is the complication of radiofrequency ablation procedure?
Complications for radiofrequency ablation. Okay. So in general, when we ablate a tissue, there's always risk of perforation. All right. There's always risk of perforation. That is number one. Number two, if we ablate too near to a conduction system, for example, AV node, then or His bundle, for example, then there's always risk of complete heart block. Thirdly, to assess this area, you need to go through a blood vessel, right? Usually the femoral vein. So vascular injury is also one of it, but mostly because it's vein, so they are quite forgivable. Number four, some ablation that you need to do it on the left side of the heart. Most of the time we're able to do it at the right side of the heart. Now if you ablate something on the left side of the heart, means that you have to go to the left atrium, you have to go to the left ventricle. Means that when you ablate, there's always risk of formation of blood clot. So there is what they call that, risk of thromboembolic stroke in this group of patients. And a lot of time we need to anticoagulate before we go to the left side of the heart. So having said so, most of these complications are very, very low. In fact, probably less than 0.5% of all ablation, except for vascular injury, a bit more. If you do a puncture on the artery to go to the left side of the heart, the vascular injury actually is hematoma, AV malformation. That is probably about 1% to 2%. The group. Well, generally, is quite safe.
Okay. The last question, maybe I can get yapped. In chronic smokers who have undergone PCI, how soon can nicotine replacement therapy be initiated? Can it be commenced within first 2 weeks of an infarct?
I don't think it's an absolute contraindication, but it's probably something to be initiated slowly, I would say. One of the problems with chronic smoker, obviously, cessation is extremely difficult, and it is an issue. However, I don't think that nicotine replacement is the thing that everybody goes for. So I would say that this is not absolute contraindication, but for the patient to discuss with the cardiologist about maybe other means to stop smoking.
Thank you very much. Back to you.
Okay, our next speaker will be Dato Yap, come.
So this is a 60-year-old man who had a stroke. That's the ECG that we are showing. And there are the options: first degree heart block, atrial fibrillation, atrial flutter, Wolff Parkinson White, and supraventricular tachycardia.
The P waves.
Some of them, the bits that actually look like P wave, but it certainly isn't consistent. So this will be atrial fibrillation. No P waves and irregular rhythm. Now, okay, let's say if this patient didn't have a stroke. Let's say if this was a 45-year-old man, a younger person, and no symptoms, okay? And this we do come across, a middle-aged, younger person, no symptoms, but the ECG shows atrial fibrillation. So I'm curious to know, in a nutshell, what in primary care we do. What can anyone tell me what you would do in real life if you saw a 45-year-old man with AF? I'm just curious to know. Any volunteers? How
Anyone?
would you?
Or maybe I can just recap Dr. Yap's question. If there's one thing that you want to talk about atrial fibrillation at your clinic, what would that be? Someone mentioned thyroid.
Anticoagulation, because I worry about the risk of stroke.
Okay, that's excellent. That's what I would do, consider doing.
So we have a volunteer mentioning about thyrotoxicosis as well.
Okay.
Screen.
Good point. So we are building up to all the things that we normally assess. So we will need to assess the risk of stroke in a patient and decide on anticoagulation. And we also need to assess one of the risk factors, which is thyroid disease. Do you think that these patients, I don't know, I'm just curious to know, do you definitely refer this patient to a cardiologist, or would you just monitor?
It depends on the CHEST-2 score. So you want to do that if they will need anticoagulants and if they are at high risk. Also target all the underlying hypertension, the age, and based on the CHEST-2 score.
Okay. So in a nutshell, I mean, I completely agree. So if I saw a patient who's young, not obviously needs anticoagulation, they have not had a stroke, then we should calculate their CHEST score. And if their score is 2 or above, they definitely should be considered for anticoagulation. 1 borderline, and 0 is no absolute need, but again, need to look at the situation. So yeah, CHEST score and some risk assessment.
Maybe a question to Ko. People used to talk about rhythm control, rate control. 45-year-old, no symptom, ECG, incidental AF. Would you still refer to a cardiologist to revert back to normal?
I need 4 hours to explain you. Okay, so I think I just going to summarize everything. So very good, because when you see someone with atrial fibrillation, of course, without the ECG, sometimes you palpate the pulse, and if you find that there's irregular, I would say most of the time is atrial fibrillation. So you just do an ECG to confirm it. It's atrial fibrillation. And of course, physical examination, you will listen for murmur, because valvular heart disease can cause atrial fibrillation. Make sure patient is not in heart failure, so you ask a history, listen to the lung, look at the whether PD edema, because heart failure is one of the cause of atrial fibrillation. Heart failure is also one of the risk factor in the chest vest. You see the chest vest, the C, is it congestive cardiac failure, is one of the risks of thromboembolic stroke. Ask the history whether the patient has history of thromboembolic TIA before, because sometimes the patient may not have a stroke, but after you ask, 2 years ago, suddenly I drive and the left hand cannot move for a while, but because it just happens to get normal back, I didn't see the doctor, for example. So there are patients like that. And of course, ask the history of, if a young patient, I always ask them whether a history of a sleep apnea, any symptom of sleep apnea. Because sleep apnea is also one of the cause of the patient having atrial fibrillation at a very young age. Shamros, if the patient has sleep apnea, I probably won't tackle the AF first, unless the patient chest vest is very high. I'll ask them to see the ENT or respi to make sure that this patient needed a CPAP machine. Because a lot of patients after CPAP, they got better. Okay? These are all the history. And then of course the blood test, you check for diabetes. If the patient has diabetes, of course, chest vest definitely is one. The patient has hypertension, check the BP is another point for that. So these are very important things, baseline tests you need to do. After everything assessment, if the patient, young patient in rhythm control, we believe that the normal sinus rhythm is the best rhythm. You imagine that if you are young and you have atrial fibrillation, when do you start treatment? When you develop, when you reach 65, that's one of the chest vests. So eventually, I can tell you that most atrial fibrillation, if you leave it in atrial fibrillation, it will never get better. I've never seen an AF that get better, unless they have a trigger, for example, like thyrotoxicosis or patient with a sleep apnea. All patients I will counsel for rhythm control. Rhythm control can be anything. We can always start with medical therapy and observe the patient, or admit the patient for antiarrhythmic therapy. Choi, do you have any comment?
I have one very valid question here from the GP's point of view, I think. So when you see a patient with atrial fibrillation at the clinic, especially someone without any symptom at all, just by chance you felt the pulse is regular, you do an ECG, it's AF. So the question is, do you send them routinely to either the cardiologist or any other person who can do an echo to look for example, neurothrombus or left atrial appendage thrombus, valvular thing? Do you advocate a
your reason? Yeah, because of the presence of rheumatic heart disease, it changed everything differently. Sometimes you may not able to appreciate the very soft diastolic murmur. No? That's very difficult. Because one of the differential is rheumatic mitral stenosis, atrial fibrillation. That's very important.
I think there's one more point, which is regarding advancing technologies and primary care. I think it will be useful to share my experience with seeing some of these patients with palpitation. So you see a patient and they have palpitation and you do an ECG and it's normal sinus rhythm. The patient still has palpitation, come back to see you a second time. What do you do? So we have forms of monitoring like Holter, 24 hours, 1 week, but you don't always capture the rhythm. Now we have iWatch, for example, and iWatch, if you, I don't know, the more expensive one, Dr. Choi would know. because I think it's in his price range, not mine. Which model of iWatch can capture atrial fibrillation?
I think you look if you look Google or you just shut up your ChatGPT, I think there's a slide that beautifully puts up 3 different smartwatch. One is of course the Apple iWatch. They have Samsung as well, and Huawei. I think all these 3 can produce very good ECG. But in terms of AF detection, by just wearing it alone, if not mistaken, don't quote me, I think the Apple iWatch seems to have a higher accuracy, although it's not medical grade.
So my experience with one patient, for example, was that the ECG was normal, but in fact the patient himself managed to record AF on the watch, and it was very useful because you could print it out. Now we know the patient has paroxysmal AF. So something to explore. We go on to the next case. Okay, this is a 70-year-old lady who collapsed. I think we'll give you a few seconds because you need to look closely at the ECG. First degree heart block, second degree heart block, complete or third degree heart block, atrial ectopics, ventricular ectopics.
Then we have more to talk about. Before you review the answer, very interesting. Maybe we describe the ECG, then see whether they want to change their mind or
not. Okay, when I was a student, and I'm sure you were all students the same, I remember my seniors always taught me to map out the P wave on a piece of paper and then you move it down and see whether it's consistently the case or not. So that's one way that we actually look at this more closely, because it's quite difficult to see the correlation between the P wave and the QRS and T sometimes. So what we are looking for, first of all, this ECG looks a bit bradycardic, right? So if you actually count out, is round about high 30s, rate of about 40 or just under. So that would suggest possible heart block. Okay, if you see bradycardia, then you can start to think about, is this a first degree, second degree, complete heart block? Okay, so it gives you a clue to look for heart block. So how do we look for which type of heart block? You have to look for correlation between the P. So again, we talk about looking for the P and the QRS and the T. So we look for the P and then see whether there's a QRS, okay? Or you look for the QRS and see whether there's a P wave before or not. And in this case, if you look at the QRS, in some cases you will see like quite normal looking P wave before, and in many other cases there isn't. So there's an alarm bell there already. Now, this cannot be first degree heart block, because in first degree heart block, every single P wave will be followed by QRS, and the gap will be exactly the same, more than 5 small squares, okay, or 1 large square. Consistently, there will be first degree heart block. So A is out already. Now, second degree heart block could be, now let's work it out. Now, second degree heart block, there are 2 types. One is Wanky bar, where your PR interval progressively gets larger and then you skip a bit. So could this be Wanky bar? Okay, if you look at the P wave, yeah, maybe, because the P wave interval is growing larger. Not sure, okay? But we say maybe, but actually Wanky bug is very unlikely, because Wanky bug is fairly benign. You seldom get Wanky bug and someone has a very, very low heart rate, okay? The other type of second degree heart block is where you consistently have two P waves to 1 QRS, and then the third part you miss it, okay? That's the MOBITS. I don't have that example to show you here, but certainly this ECG doesn't look like that. So lastly, if we look at complete heart block, and you look at all the P waves, when we actually map out each of the P waves, you will find that actually the P waves are very consistent, okay? That means our sinoatrial node is actually working, and but it's not correlated to the QRS complex. Okay, so from the top, the signal is still working, but it's not conducting down to the QRS where the ventricle actually then forms a beat. So this is complete heart block. Okay, so this is what we manually do, and actually it's sometimes hard to see. For example, you see the one in the T wave. If you didn't map this out, you will find it very difficult to see. Yeah, this one you can still see. That one, if you look at the other T waves, this one looks like a bit like a more peak, you know, because the P wave is actually superimposed onto the T wave. So it's actually very consistent. So this is very typical of complete heart block.
So, Dr. Choi, so Dr. Yap is saying that complete dissociation, there's a block at the AV, that's why we call it AV block, atrioventricular block. The P wave is not conducted to the ventricle, but how come we have all these still have ventricles?
That's a very good question. So in the presence of total dissociation from the atrium and the ventricle, in the presence of that, how come there are still QRSs? Is that right? Is that a question?
Yes, correct.
Yeah, so this
It
is
should be a flat line, right? Or maybe
should be a
just
flat
P
line.
wave
Or
only.
yeah, so
Just
when
P
we do
wave.
see that, obviously sometimes the patient will not survive. But yes, if you Google, you can still find ventricular standstill, where all the P waves are not conducted. But in this case, fortunately for the patient, they have this what we call as escape rhythm, and it can come at the different levels. Maybe Dr. Koh, you want to further elaborate on that?
In a human heart, God designed as a backup plan, always a backup plan. So the fastest automated tissue is our sinus node. It beats around 60 to 100 beats per minute. So after that, the AV node itself surrounding the AV nodal tissue also have its automaticity, so about 40 to 60 beats per minute. Obviously, the one that is faster is going to take control, which is the sinus node. That's why you always see sinus node. But in very fit athletes, sometimes the AV node also very active. So sometimes you can see a junctional rhythm in a fit athlete. Okay, so that's our first backup pacemaker. Certain people have atrial pacemaker rhythm, means that the other other automated cell in the atrium that can act as a pacemaker. Now, if you're blocked at the AV node area, some of the perinodal tissue still can fire the escape rhythm at about 40 to 60 beats per minute. So sometimes the junctional rhythm are still about 40 to 60 beats per minute. It comes from the perinodal area. Now, what if you block lower than the AV nodal area, means that the His bundle area? You have a third backup pacemaker, which is the ventricular muscle. Ventricular muscle can escape a pacemaker rhythm about 20 to 40 beats per minute, but the problem is it is not very stable type. It can sometimes doesn't want to appear. So if you see a broad complex bradycardia, means that the escape rhythm is from the myocardium. Remember I said broad complex QRS usually origin from the ventricle. Now if you see a broad complex instead of a narrow complex, broad complex is something more urgent, it's emergency. You need to implant a pacemaker or put a temporary wire on that day itself.
Any third degree or complete heart block patient should be considered for permanent pacemaker.
Yep.
And in general, we will often see this only in heart disease, a significant heart disease. So we really talk about the inferior MI and occasionally the anterior MI, but basically is usually only happens in patients with significant heart disease.
Now I think on and off you will do X-ray and then suddenly you see devices in the heart. So just to learn about devices, 78-year-old man has a device implanted. What is the likely device shown in the X-ray below? I think this is very clear, although it's not too clear here, but I'll give you a tips and tricks how to differentiate which devices.
I think from here it's a bit hard to see all the wires. You have to give some tips.
The tips is there's 2 wires only. Are we dealing with a single chamber pacemaker or dual chamber pacemaker or dual chamber implantable cardioverter defibrillator, or D, a cardiac resynchronization therapy device with ICD. Wow, how to differentiate?
Sorry, honestly speaking, I don't know about this one. But I think it's a dual chamber for sure. Because there's, I can see there's 2 wires going to the left and right side of the heart. But I'm not sure whether it's an ICD or pacemaker. Thank you.
Thank you. I think it's a good start.
Yep, you're not supposed to know. So this is a, who says a single chamber pacemaker, angkat tangan? Nobody lah. Who says the dual chamber pacemaker, angkat tangan? Alright. So this is a dual chamber pacemaker. Now, just now, Dr. Yap's case shows that a complete heart block, they need a dual chamber pacemaker. What do you mean by a dual chamber pacemaker? It means that there's pacemaker wire going to the atrium and another pacemaker wire going to the ventricle. So you can see the green one is labeled on the right atrium. The blue arrow indicates that the pacemaker wire is in the right ventricle. So the device, actually, of course you haven't seen any device, but I think the trick to differentiate ICD and a pacemaker would be the blue color lead, this lead, the RV lead. Now this RV lead, if you look, it's not very obvious, kan? Later I'll show you another one, then maybe you can differentiate it better. Now, for dual chamber pacemaker is indicated for complete heart block because you have no association from the atrium and ventricle. Now you need to resynchronize them back. So you need to sense the P wave and then tell the pacemaker to pace at the RV. So in a complete heart block, you need a dual chamber pacemaker. If not, then you will be only pacing the ventricle without sensing the A. Then the patient will get something called a pacemaker syndrome. Means that the atrium is contracting at the same time the ventricular contraction. Then you get a pulsatile neck, discomfort, all these things. So nowadays, dual chamber pacemaker is indicated in complete heart block. Only in cases where you think that the atrial lead has no function, for example, in persistent atrial fibrillation, then you can implant simpler pacemaker called a single chamber pacemaker into the ventricle. All right, because you don't need to sense the atrium. The atrium is always in AF, and you cannot pace atrium that is in atrial fibrillation. Now, this one is very obviously different. I think from behind you can see or not, the lead.
Yep.
Okay, this is a big clue already. A different bit from the previous one. If I may go back a bit. Okay, just observe the size of the device. Just observe the size of the device. I don't know how to describe how big or how small, but just with the eyeballing the device size versus this one. Obvious now. So now the option is still the same. A, B, C, D.
It's like an SUV, the size. So you mentioned
ICD, C.
C. Very good. That is correct, but I forgot to tell you that, sorry, it's not very clear. If it's clear, she've probably gotten it correct.
Yes, it's not clear.
So there's one lead in the atrium. There's one lead in the RV. And actually there's another lead somewhere here. Yep. So there are 3 leads now we are dealing.
It's poorly defined from here, the resolution.
Yeah, I know. Not a good projector. Okay, so now we have 3 lead system. A bit suddenly upgrade, very complicated. Okay, we go to 2 choices. Who say is a dual chamber ICD? Hands up. Okay, good. Who says cardiac resynchronization therapy with ICD? Hands up. Okay. Most of you all got it correct. Is the CRTD. Okay. Now, this one is a bit more, also not very clear. I think next time we have to have a LED screen. Now, this is the one that I want you to take note. Can you see the difference, the RV lead? Choi, why is there a difference there? What is the white color thing?
Yeah, from here we can see that it's very thick, you know. So something must be extra lah compared to the first pacemaker, right? So I would say some kind of coil would be there, you know, some metallic coil that thickens up the whole lead. Maybe that's the role of the defibrillator.
All right, and the device is very big, a big device because they need a big capacitor to charge. You need to charge battery before you deliver a shock. Right? Implantable cardioverter defibrillator is basically the one that you see in the movie, the 2-pedal shock the heart, miniaturized in the small system. And you still need to shock from 2 different locations. Where do they shock from? The shocking coil, which is the one that Dr. Choi described. The whole thick thing which is radio opaque. So that's very easy to identify in X-ray next time. If you see this X-ray, you see a radio opaque thing in the RV, that is the ICD system. So when they shock to the can. And it can reverse also, it can shock from the can to the coil. So these are the ICD system. You can see it's very big because of the capacitor. Okay, then there is this another wire there, blue color. What is that? It is a left ventricular lead. And how do we place the left ventricular lead? It is through the coronary sinus. The coronary sinus is the one that wraps around the atrial and ventricle on the left side. That's how we reach the left side of the heart. And why do we do it in these patients? Anybody can tell what is the underlying disease for this patient? If you see this, definitely this patient has certain indication for CRTD.
The indication for a extra wire in the left side system?
Actually, the answer is there. It's for symptomatic heart failure despite your 4 pillars of therapy. If you look into a guideline, and they still very symptomatic, but you have to do an ECG first and make sure it's the left bundle branch block. Why? Because left bundle branch block tells us that there's dysynchrony of the ventricle. So if you have a dysynchrony of the ventricle, imagine that the heart beating from the right side first and then left side. Definitely is not going to help further in the ejection fraction or the symptoms. So you have to synchronize it both sides. Pumps together, pace together. Some of us call it the biventricular pacing. Pace together. So that it will improve the symptom of heart failure. So the CRTD is indicated for symptomatic heart failure patient. ECG has to be left bundle to have the best result. And what is the function of the atrial lead? Of course, the atrial lead, you still need to synchronize the atrium and ventricle. You cannot just pump both ventricle without knowing without synchronizing with the atrial. Sense the P wave, atrial contraction, and then pace both ventricles together. So you have that's why you call it a cardiac resynchronization therapy. And it improved in about 70% of the population with left bundle, but still got about 30% that is not responding to this treatment. All right, any question?
Dr. Koh?
Yeah.
From your experience under your belt, do you have any patients with typical left bundle branch block whom you have implanted a CRTD and responded to it, and how would you share your case?
So far the cases they respond very well. I got most of my referral from Dr. Cherba. So is our patient okay so far?
So far they're doing well. They're doing well because they are very selected cases.
Yeah, they are actually quite ill to begin with. If you imagine that you are on medical therapy after many years, still not responding to treatment, once you respond to a CRT, you really feel much relief. Yeah.
We have a question here.
I would like to know, normally how does a patient feel when a shock is being delivered?
Okay. Now, a lot of times, the ICD itself nowadays are very smart. Smart in the way that they can detect ventricular tachycardia or ventricular fibrillation, and they roughly give a time before it delivers a shock, so that the patient won't feel the shock. So what they do usually, they will try to pace first and override the ventricular tachycardia. So these are the anti-tachycardia pacing. So the patient, before they have described the pain, sometimes most of them are aborted. They feel palpitation because the ICD is trying to override the ventricular tachycardia. And most of the time, it will abort before it even need to shock. So that abolishes the need for shock. Second, let's say anti-tachycardia pacing fails, the capacitor will start charging, and the patient usually will feel giddy. And most of the time, when it's shocked, the patient is semi-conscious, and then the patient will say, hey, what happened? But a lot of time, it's shocked too early, and the patient described to me, it's like a sudden kick in the chest, or somebody punched very hard in the chest. These are the usual description from the patient. I don't know about other, where is Dr. Chai? Your patient got described to you or not? Any shock? Yep. About the same, kick in the chest, a shock sensation. What else they describe, Chai?
Some say they could be a phantom shock, maybe. Some describe them as phantom shock. So even though without the shock, they always feel that they are getting a shock.
Yeah, that's why we try not to shock a patient if possible. So the ICD programming is very important. Most of the time, the first shock, we have to look into the ICD and try to see whether the shock, number one, is appropriate or not. Meaning that, is it really shocking at a VT or shocking at something else like atrial fibrillation? So that's the first thing. And then when it's shocked, we try to prolong the tachycardia and try to adjust it. There are many ways to try to reduce the shock. If not, really the patient is psychologically impacted. No? I'd rather die. No? Straight away, why you put ICD, I'd rather die.
We have a question here, I think quite relevant in a GP setting. Should a patient with a pacemaker come to the clinic, but when you actually do the ECG, you don't see any spikes? Does that mean that the pacemaker is not functioning? Or how do you approach this kind of scenario?
Very good. So if you see a pacemaker, not this one, this, for example, if you see this patient in your clinic, you do an ECG, like a normal ECG. First of all, you have to really make sure it's normal ECG and not atrial pacing ECG. Nowadays, the pacing spike is very small because they only use minimum amount to pace. 0.4 volt, 0.5 volt, and the ECG may filter it. So if you don't see any pacing spike, even a minute one, then you look at the heart rate. The heart rate, if it is about 60 and above, that means what? That means that it's a normal rhythm, you're right, but it doesn't mean that the pacemaker is not working. Remember that pacemaker only work as how you program them to work. And most of the time, for example, like 6 sinus syndrome, you only program them to pace only when the heart rate drops below a certain level. I always program 50 and below. So if the heart rate is 60 and above, the pacemaker won't pace, which is doing their job, basically. Now, if you suddenly have a pacemaker that is 40 beats, I mean the ECG is 40 beats per minute, it has a pacemaker, then you have to suspect maybe the pacemaker is not really functioning well. Of course, most of these cases are usually patients with a 6 sinus syndrome, because 6 sinus syndrome, not always you need to pace the heart.
Yeah, so just to share with you as well, I used to have this very senior consultant. He gave me a quick tip. Sometimes you have a patient with a pacemaker and you don't know whether the pacemaker is working or not. So you just put the patient on the ECG and then you wriggle the pacemaker a bit. So as you wriggle the pacemaker, there's a sensor there. So the pacemaker will think that this guy is probably running. So the pacing rate will increase. So if you're lucky enough, you will probably be able to see a sudden rise in the heart rate on the ECG, then you know that somehow this pacemaker is most likely functioning.
Yep. These are pacemaker with rate modulation, meaning that nowadays, so I told you, right, pacemaker very smart. If you put a patient on a pacemaker, how do the pacemaker know that the patient is running? You can have a 6 sinus, but the 6 sinus, when you run, you cannot achieve a heart rate of 90 beats per minute. Then you also feel symptomatic, run a bit, shortness of breath. So these are called 6 sinus syndrome with chronotropic incompetency. You run, the heart rate don't want to go up. So pacemaker has this something like your iWatch or your smartwatch, like a what? Tachymeter. They depend on your movement. So if you run, the pacemaker will think that you are running. And if Dr. Choi wiggle the thing, he thinks that the pacemaker is actually running, I mean the person is actually running, then it will start increasing the low rate, going higher, until up to the one we set also, usually about 130 beats per minute.
What about putting a magnet over the pacemaker?
If you place a magnet over the pacemaker, you have to be a big one. If you put it over the pacemaker, then the pacemaker will change the mode automatically to what we call a VOO mode, means that we just pace only. Now this situation are usually used in, for example, operational theatre, OT, where suddenly you're not too sure the heart goes very brady. Sometimes the diathermy may cause interference to the pacemaker and the pacemaker is not functioning. You put a big pacemaker, the donut-shaped pacemaker, into the magnet, and then it will start pacing at certain rate depending on the company.
I understand that those with Brugada syndrome also indicated for this device, and how frequently actually you all come across patient with Brugada syndrome?
This is no longer true. Last time we used to implant a lot of ICDs in Brugada syndrome with even family history, because we always thought, wow, Brugada, they're going to die in the sleep. So we even collected a lot of data on all our Brugada patients in IJN, and we noticed that actually most of them doesn't really need an ICD, which is corresponding to the worldwide registry. Most of the time now, we don't implant routinely ICD in Brugada patient, except they presented with symptoms that we think is related to cardiac syncope. So it means that they must have symptoms, fainting episode. Or of course, presented your ER with a ventricular fibrillation, then resuscitated cardiac arrest, then no question about it, then you implant ICD. Brugada syndrome, if you see in your ECG, in your clinic, asymptomatic most of the time, do nothing also, but you have to advise the patient that you have these ECG changes. Please be careful, especially if you are having high fever, you have to quickly take paracetamol to cool down, because fever tends to aggravate the Brugada ECG pattern and sometimes goes into the ventricular fibrillation. Any other questions? Okay, so now you can identify at least the ICD lead from the normal RV lead. This is very clear cut already. All right. So I will leave the Dr. Choi to show his cases.
I'm not too sure how relevant this rhythm is in your clinical setting, but I can safely say that when you see one, it's not a very good day. Anyway, we have here a gentleman, 70-year-old man. The reason why men die sooner. History of myocardial infarction, all right? Presented with syncope. So just a very quick one. What do you think it is? Is it A, hyperkalemia, B, ventricular tachycardia, the infamous VT, or C, maybe a bit more academically related, AF with aberrancy, or he's actually okay, he's just having seizures with motion artifact. So maybe just someone would like to volunteer? Is it clear on the back there? The ECG? So maybe I can set the ball rolling. We have two different, how I approach the ECG is actually standing right at the back there. When you see the ECG from far, ask yourself, what is the first impression? The first impression that I get from this ECG is, it's pretty fast. That's the first impression, I think the most important impression. The second question is, why is it fast? Is it normal kind of fast, like a sinus tachycardia, because you're going for exam? Or is it something abnormal? Then we start searching for abnormal waves, which I think everybody will agree that the first few seconds, they're all broad. They are broad and they look horrible because it's very fast. So, and after that, you see some narrow QRSs and, oh my God, they look normal to me. So I think those are normal beats. So we call these capture beats. In fact, the first normal looking beat is actually a fusion beat, which is actually half of the ventricular beat and half of the normal beat. So when you fuse them up, you get fusion beat. Well, this is quite classic. You get broad complex, you get fusion beat, you you get capture beat, cannot go wrong lah. It has to be ventricular tachycardia. Okay, so I'm glad that we're on the same page. So just to share with you, in case you ever bump into one, and this is how you decipher the ECG. It cannot be AF because it's too regular, the QRS complexes. Hyperkalemia, I mean, it's just electrolyte. We can't tell unless you do a blood test. But typical hyperkalemic ECG changes is not like this. Dr. Shamros has clearly shown to you. It depends on the degree of hyperkalemia. The worst case scenario is sinusoidal. It's most likely brady before they go into the other arrhythmia. Seizures, I think seizures, we know when you have motion, tonic-clonic, it's always faster, higher frequency than this. This is a bit too slow for seizure, so it's a VT. Now, second ECG. Based on my earlier method of analyzing ECG, again, from far, what do you think? The first thing, the one thing that you think is abnormal, it's too fast. That's the first thing. All right. So of course you can see a lot of broad complex beats in the middle there as well. Then you ask yourself, this looks a bit different from the first ECG. Why? Because you know the first ECG, the broad QRS, they're all the same. This looks a little bit bizarre because you have some narrow ones, then you have some shorter ones and taller ones. So to some extent, it's a bit polymorphic, meaning that it's more than one morphology. So what could it be? Let's look at the options first. Is it severe hypokalemic ECG changes? I hear a no there. All right. So is it polymorphic VT? I just self-explained it is. AF with Wolff-Parkinson-White. Someone shaking their heads. And lastly, SVT with Bracey. Just to cut things short. So this is, again, a ventricular tachycardia. The only difference is that it's polymorphic VT. And this is a very unique polymorphic VT, which I think everybody will agree. Most of the time, they will fail. Because it's so fast, it's so rapid that these patients won't survive standing. All right? And the reason the arrow is over there, you can see a blue arrow on the second beat. This is a classic arrow, classic beat. We call this a PVC. But why is so special with a PVC? I mean, we all do know PVCs, right? Remember one of the slides, someone asked how important is an isolated PVC. Now, this isolated PVC is very important because the reason why the patient went into TOSA is because of that PVC. You don't believe, right? Okay, never mind. So what happens after that PVC is that you have a pause. It's natural to have a pause after a PVC. Now the problem is this patient had some kind of azithromycin, had a bit of diarrhea, so underlying hypokalemia is already on board. And the azithromycin just pushed the QT a bit more. So this patient had a prolonged QT. Now, one bizarre PVC coming in at the right time prolonged the pause. So that made the next QRS QT even longer. So that is why when you have another PVC on top of the next sinus beat, this patient goes into a TOSA deploy. That is why the culprit is actually that PVC, that blue arrow PVC. Now this is one example where an isolated PVC is not so benign after all. This is a classic TOSA. The treatment is of course magnesium, treat the underlying problem. But I thought it's nice to share because when you see a polymorphic VT, they are always unstable. I had a patient once, she kept on fainting, even up to ER, no. Kept on fainting. And finally the MO, not our ER obviously, finally the MO decided to do an ECG. And only then they realized it's actually a TOSA because the patient is quite young. All right, so maybe I just pause here for a while. Any question from the floor? Or Dr. Ko, you want to comment anything?
Yeah, any question from the floor? So I think we have shown a lot of these broad complex tachycardia. And again, I just want to emphasize, most of the time if you see a broad complex tachycardia, the broad complex usually comes from the ventricle. So you are almost always correct. Like if you say this is a ventricular rhythm, this is a ventricular tachycardia, this is a polymorphic VT, this is a PVC, if you see a broad complex. So, yep. And actually your history is quite classical. Why I think Dr. Choi showed this? Because I have a lot of patients, for example, with heart failure, they are on LASIK or furosemide. And when they presented with diarrhea, they are often given Lomotil plus ciprofloxacin, or sometimes they will give azithromycin. Now, why all this history matters is, a lot of times when you have diarrhea, you are on furosemide, you tend to get hypokalemia, hypomagnesemia. This prolongs the QT. This is the first hit already. Then secondly, you will hit it with another QT prolonging drugs like azithromycin, plus third hit Lomotil. Usually these 3 hits usually will cause toss-up.
Yeah. So I'll just move on very quickly. This is, I think, my last slide. What does,
everybody should get this correct, huh?
Yeah, by now.
By now.
Correct. And that's the trick. You look at the option, there's actually a trick. Okay, never mind. Let's just keep it open for now. Is it a pacemaker, dual chamber pacemaker? Is it some kind of susu? It will be a massive one. Not cosmetically pleasing, this susu, I think. Or is it lung cancer? Or is it APO? Any volunteers? I will probably need a volunteer for the correct answer. So anyone feels it's a pacemaker? Yeah, but after Dr. Koh's lecture and slide, I'm pretty sure some of you will beg to differ that this is not a pacemaker.
Why is not a pacemaker? Anybody can pinpoint one thing that I mentioned just now.
Looks a bit weird, right? This pacemaker system, not the most pleasing looking.
Yes, it's the RV. You see the coil, the very really opaque coil there, and the device is big.
Yeah, Dr. Koh mentioned this is like a big size generator, and then the coils are all thickened. So it has to be an ICD, yeah. So this is actually a dual chamber ICD. In fact, this dual chamber ICD has got 2 coils, one in the RV and the other one up in the SVC. So some of us, we are a bit cautious, I would say. So we want to have different vectors to shock the patient, should the patient need a shock. So one coil is not enough, they put another coil up there. So more options, just in case the patient has a BF. Yeah. So this is a dual chamber ICD, all right? So just give me 5 minutes. I'd like to re-emphasize what Dr. Koh has mentioned, how ICD can save lives. So this is a typical defibrillator, but in a patient with heart failure, they tend to get VF and they probably would die from VF, right, if you don't treat them. So unless you carry a defibrillator around with them, otherwise it's impossible. But we can do that nowadays by putting an ICD. But how does a defibrillator work? We watch movies all the time and you see people getting the VF and you shock them. But have you ever wondered how a shock actually terminates a ventricular tachyarrhythmia? So a very simple understanding is that when you have a ventricular tachyarrhythmia or any kind of tachyarrhythmia, as long as there's some kind of reentrant going on in the muscle, in the scar, in the half scar area, it's like a crowd, a bunch of people talking to each other, not listening to the presenter. I don't mean now. I mean, everybody talking, the guy, the gossip, they're gossiping. So nobody is listening. And it's perpetually like a cycle, keep on spinning around in the muscle. That's why the VTAC wouldn't stop, So the only way to shut them down is the presenter giving a loud knock on the microphone. Then everybody stop. And they will start to listen. And now this is the role of a shock. So when you deliver a huge shock with such current across the chest, across the heart, all muscles will get depolarized. Whether they are half depolarized, they are completely depolarized, it doesn't matter. We sync them up so that they stop talking and they start listening. And that's how a defibrillator works. All right, and this is an example. Real guy, this footballer. And this guy is very interesting because he actually has an ICD. During one of the games, he has cardiomyopathy. So someone put in an ICD in him because he has high risk of VF. And one day, he was playing football, and you can Google him up. It was recorded, he collapsed. Not surprising because he got Hokum, right? So he developed ventricular fibrillation, and he collapsed. And the defibrillator shocked him on live TV. So you can actually see the guy jumping. And the best part is, he woke up and he walked up the pitch. So this is the only video I could ever find online that demonstrates very well when you place an ICD in the correct patient, you actually save lives. And this is an example. So yeah, that's how I end my slide. Thank you.
All right. Thank you very much. I think that's the end of our session. So once again, thank you to all the presenters. Thank you very much. A round of applause for them, and also a round of applause to all yourself.